Right. Hi, everyone. I'm just gonna give it another 5 minutes to let as many people join as possible. So we'll start at 5 minutes past 8. Right. Okay. So that's 8 and 5 minutes. So we'll go ahead and start. Thank you, everyone, for joining us today for the second episode of the urology series. So today we're going to be talking about catheterization and acute urinary retention. And this will be the second part of a 12 teaching series, basically, in urology. If you could give me the next slide, please. So before we go ahead and start, I'm just going to give out a quick message for our sponsors. So CPD.me, they're basically a new portfolio company. And what they do is basically give us a handy drop down interface for your career and development. And it's suitable for anyone who works with the GMC, with the NMC, or any healthcare professionals in general. So if you're interested in that, use our QR code with Mind the Bleep and you can get 50% off. And now I'll go ahead and hand over to Sinan, who's going to present our subject today.
Thank you, Zach. My name's Sinan. I'm a ST5 urology registrar in Aberdeen. I'm currently out of program doing a PhD. And I'm going to talk to you today about urinary retention and catheterization. So the objectives that I'd like to cover are to know the causes of urinary retention, know the indications for catheterization, be familiar with different catheters and catheterization techniques, and be familiar with catheter complications and post-catheter care. So catheterization is a key procedure. You should all, by the end of medical school, know how to perform a female and male catheter. It's a very common procedure, as I said. So in a study by Shkoukani et al. In over 250 NHS trusts, about 13% of patients were catheterized. So that's over 1 million patients in a study looking at over 9 million patients. So very common procedure, everyone needs to know how to do it. And as expected, male catheters are more common than female catheters. So if we think about cause of retention, what I'd like you to think of the bladder as is a muscle that stores and pumps. So if the muscle is overstretched, then it can fail to work. The best way to think of this is if you're trying to lift a weight, say you're trying to lift a weight with your biceps. If your biceps are straight out and they're stretched to the max, it'll be harder to initiate that flexion rather than if your arm is already halfway flexed. So if the muscle is overstretched, it can fail to work. If there's not enough force in the muscle, then the bladder will not empty. And if there's too much outflow obstruction, then the bladder will not empty, and urine may even reflux up the ureters because there's nowhere else for them to go. And that causes something called hydronephrosis. So if we think of it, as I said, pump and so storage and pump. So pump failure would be if it's overfilled and overstretched muscle, like we said. Neurogenic, so any disease where the nerves don't talk to the bladder, such as multiple sclerosis. Detrusor failure, so failure in the muscle itself. And infections can irritate the bladder and the muscle, so you'll have pump failure. Of course, anesthesia, a very common reason why people go into retention is post-anesthetic. And then if we look at blockages, so outflow blockages, the obvious one here in men is BPH, but also cancer, either of the prostate, bladder, urethra, penis, vulva, or gynae cancer, anything that causes a mechanical blockage in the outflow. You can get some weird and wonderful neurogenic things where the bladder and the sphincter are not in sync. So they both contract at the same time. That's very rare. A prolapse, so especially vaginal prolapse, will kink the urethra and cause outflow blockage. A stone may get stuck and cause blockages there. Constipation, and of course trauma as well. So a number of different causes. So the indications for catheterization, obviously there's retention, which is we're talking about, and this can both be acute or chronic. So as a general rule of thumb, acute retention tends to be painful, whereas chronic retention is painless. And chronic retention happens more with men, for example, with BPH, who over time their prostate has grown and their bladder has just learned to stretch and stretch and stretch until they're retaining over a liter. But because their bladder's stretched over time, they're not feeling pain as much. Another indication for catheterization is urine output monitoring. So especially for patients undergoing long surgeries or patients with sepsis. So if you've heard of the sepsis 6, it's one of the things that you need to do, monitor the urine output. We talked about preemptive or surgical planning, but also if you're doing any resections in that area and you want to preserve the urethra, then a catheter is a good thing to have in so you know where your landmarks are. Fistulas, so a connection between the colon and the bladder, colovesical, or the vagina and the bladder, vesicovaginal. So these are abnormal connections, obviously, and the best way to manage it is to put a catheter in initially, so that urine isn't leaking out the vagina or leaking into the colon. And in a similar way, certain perforations in the bladder you can actually treat with a catheter, because the bladder stays nice and collapsed, and it gives the bladder a chance to heal and close up that hole. Administration of treatment. So for people with bladder cancer, sometimes we give them chemotherapy inside the bladder, and we do that using a catheter. A very rare reason is incontinence. As a general rule, you don't catheterize someone for incontinence, but very, very rarely, sometimes if it's causing them a lot of symptoms and bother, you do. So what are the different catheter types? Well, obviously we talk about some routes that you can put a catheter in. So there's the obvious one, which is urethral. And there's a two-way catheter that you can put in, and this is from a simple Foley, which I'm sure you've all seen before, a yellow Foley catheter. It's called a two-way because it has two channels, one to drain the urine out, the other to inflate the balloon. You can have a long-term or silicone catheter, which is a bit more stiffer than a Foley and helps navigate around big prostates. You can get a coude tip, which is different from a straight tip. Again, this helps meander around a big prostate, which you might not be able to get through with a straight tip. You can have three-way urethral catheters, and this is where you have the balloon port, the drainage port, and an irrigation port. So this is for people who have blood in their urine that's clotting inside their bladder, and you can put in a three-way catheter to wash out and irrigate the bladder out. It's also used when we're doing resection inside the bladder, endoscopic resection, and there's a lot of bleeding. So post-operatively, we'll leave a three-way catheter in to wash out the bladder so that the blood doesn't clot inside the bladder. You can have a suprapubic catheter. So that's a catheter that goes straight through the tummy and into the bladder, and it drains that way. And this is for people who can't have a urethral catheter, or they need a long-term catheter for life, and a urethral catheter is causing complications. So that we put one through the tummy because it's a lot easier to manage. You can have an intermittent or a once-only catheter, and this is a catheter that the patient will use. We teach them how to do intermittent self-catheterization, and this is used for people, for example, whose bladder doesn't empty, who has a neurogenic bladder, for example, where the bladder just doesn't have the nerves connected to tell it to squeeze. So in people with MS, for example, so they would use that. And of course, with all these catheters, there's different sizes. So they normally range from 6, which is very, very small, often used in pediatric cases, to 26. And the most common ones, realistically, that are stocked on the ward, on an adult urology ward, will be from 12 French to 18 French for a two-way catheter, and a 22 to 24 for a three-way catheter. So a lot of people try to find out what the size is when they're picking up the packaging. But if you remember the color at the end, so if you see in the top, that Foley catheter is a red top on the balloon port, so that's an 18 French. So if you remember the colors, then you don't need to look at the numbers. And you just need to remember a few, that mainly the white is 12, green is 14, orange is 16. Those are the most common used catheters. So if you remember those, you won't need to look up the size. So catheter technique. So I'm sure you'll learn hands-on training how to put a catheter in, but tips for, especially for difficult catheterization in men, obviously you have to prepare everything on the trolley. It has to be aseptic technique. And my tip is to take everything out of the wrapping, so it's all there and ready. You've got your instiller gel, which is jelly with local anesthetic that helps. And often when you take it out, it's quite stiff. The plunger is quite stiff. So my little trick is to pull back a little bit, and that just makes the plunger nice and loose. Then obviously you prepare the field and clean. So the best way to get the urethra nice and straight is to hold the penis taut and straight. So basically point up to the ceiling as taut as you can. That straightens out the urethra and makes your life a lot easier. You insert the instiller gel relatively quickly, and then you hold the urethra shut. If you don't, then all the jelly will just come out. And then you take your catheter. If it's a man, I would say they need at least a 16 French, unless they have a history of narrowing or strictures in the urethra, and then you need to go smaller. Insert the catheter slowly. You'll eventually reach a bit of resistance where the prostate is, at which point you drop your hand down to get round that curve that you see in that anatomy picture in the top right. So you drop your hand to get round that curve. So you point the catheter up towards the ceiling, and then you push. If you're using a coude tip, remember that's the bent tip at the end. You have to ensure that the tip is always facing up and it doesn't spin around whilst you're putting it inside. There's often a line on one side to help keep you orientated. With female catheterization, it's fairly easier, but people still get into trouble. The urethra is always between the clitoris and the vagina, unless they've had major surgery down there or resections. And in older ladies, the urethra might sort of migrate down more towards the anterior vaginal wall. So just be aware of that. What can go wrong with catheters? So the main problem is false passages. So this is a channel that's created extra anatomically, so not where it's supposed to be, and it's often beside the urethra. The main place where it happens is at that bend around the prostate. So you can see in that diagram where that catheter is digging into, and it's not following the urethra. And if you look down a camera, down the urethra with a camera, you'll see that there are two holes. The one in the middle is the true lumen, and the one at the bottom or to the side, the less darker one, is the false passage where the catheter's just been digging in and creating a false space. Paraphramosis. So in uncircumcised men, someone will retract their foreskin, put the catheter in and forget to replace the foreskin, and that causes a constriction where the foreskin gets engorged, the glands get engorged, and it's very painful and it's unnecessary. So that's almost always the fault of the person who put the catheter in. So that shouldn't really happen. Urethral trauma, obviously, and bladder trauma. These are quite rare, thankfully. With a suprapubic catheter, though, the complications are a bit more like a surgical procedure. So some people actually consent patients before putting in a suprapubic catheter, but the main complications with any surgical procedure: infection, bleeding, and pain. There's also a risk you can perforate the bladder. So if you're going through the tummy into the bladder, but sometimes a loop of bowel can come down, and before you know it, you're skewering the bowel into the bladder. Normally there's a space which is extraperitoneal, so where bowel is not present, and that's just above the pubic symphysis. So technically, bowel shouldn't be there, but sometimes it is. And that can lead to perforation, peritonitis, and death. So there's about a 1 to 2% risk of death with suprapubic catheter. So it's not just a routine procedure. And of course, damage to surrounding structures. There are some contraindications. So some people that cannot have a suprapubic catheter in, if they have bladder cancer, you can't put one in because it will seed. The tumor will seed up the catheter tract. If they've had previous laparotomy, there'll be more chance of scar tissue and more chance that one of those scar tissues is kinking a loop of bowel in your way. If they're on a blood thinner and you put a suprapubic catheter in and it bleeds and bleeds and bleeds and then clots, that's not good. So that's a relative contraindication. And if they have any vascular grafts that are going across the tummy, such as a femoral crossover graft. So you've put your catheter in, it's draining urine, you're very happy with yourself. What next? Well, you need to consider a catheter sample for urinalysis or microbiology if you think there's been some infection that's caused the retention. Documentation is very, very important. You need to write down what the residual volume drained in, and you need to obviously give it time to drain. So I would just give 5 minutes. So by the time you've packed up your stuff, you've put them all in the bin, gone and washed your hands, and then started to write, that's about 5 minutes. You come back and see what's in the bag that attached to the catheter you've just put in. You need to document the color of urine. I know that sounds silly, but you need to say if it's clear urine, concentrated urine, smelly urine, pus-filled urine, if it's bloody urine, so hematuria. All these things are really important. On the catheter packs, there are normally catheter stickers with batch number and things like that. Just try and stick them in the notes. And when you get senior enough, you have to try and think of the next step. So you've put a catheter in, what's next? Do they need it removed? Do they need it changed in the community? How will they empty it? Are you just going to attach it to a leg bag or just have a flip flow valve at the end? So you need to think of the next step. If your patient has a retention over 800 mils, then you need to monitor for something called post-decompression diuresis and for hematuria. And I'll explain a bit about that in a second. If they do have a lot of urine, you have to ensure that the bag isn't full or bursting straight away. You'll need to drain it otherwise, because it'll just mean that the bladder's still not empty. So you haven't really done your job. And then just have some common sense and ensure the patient is safe and they won't pull at the bag or the catheter. So if you've put the catheter in, don't put the bag on the other side of the bed that the patient's getting out of, because they'll just roll out of bed forgetting they have a catheter in and tug at the catheter and it might come out traumatically. So just be sensible. So in people with large volume retention, they get something called post-decompression problems. So it's normal for the urine to turn from clear to a rosé or hematuria, so dark blood or red blood urine. And the reason for that is the capillaries in the bladder have been stretched so far, and then when you put the catheter in, the pressure is taken off suddenly, so they become quite leaky and they'll bleed a bit. And that's why initially you get the clear urine that's been in the bladder, and then as it shrinks and fresh urine is produced, you start to get that bleeding. So it'll turn from clear to hematuria. That's normal. You don't need to do anything about that. It will clear with time. The only time you need to call a urologist is if it's starting to form clots and it's blocking the catheter. Post-decompression diuresis. So you get a diuresis effect, which means that you produce a lot more urine than usual after decompressing large volume retention. And this is defined as more than 200 mils per hour. So you need to ask the nurse to monitor the output. This is obviously after you've recorded the residual volume. So they need hourly input and output. And the diuresis part is, in a sense, physiological up to a certain point, because the patient, whilst they've been in retention, has been retaining salt and water that has accumulated, especially during the period of renal failure. So they're going to want to clear that, so you get a diuresis effect. You get loss. I don't know if you remember your diagram with the nephron, but it all works on a concentration gradient, and you'll get loss of that concentration gradient because there's diminished flow of urine through the nephron. So if there's no flow, then the gradient won't be there. And the third reason you get a diuresis is because all the urea that has built up causes an osmotic effect. So to a certain extent, you'll get physiological response, but you need to make sure that they don't get dehydrated from diuresing too much. So you need to do a lying and standing blood pressure to measure for a postural drop. If that's present, then you'll need to treat them with replacement fluids, because they won't be able to keep up the fluid intake orally to match how much they're losing. And if you don't do that, they'll get really dehydrated, and that's potentially fatal. So you normally start replacement fluids at 50% of what they're losing. So if a patient had 1 liter in their bladder that you drained, and then over the next hour they peed out 2 liters, but they only drank 1 liter, then they didn't drink as much, then you need to replace 1 liter, which is 50% of what they've lost, so the 2 liters they've lost. And there's no way they'd be able to drink all of that in that amount of time. And of course, you need to monitor their urea and electrolytes until the diuresis settles and their renal function has improved. So there are some other advanced urological techniques that you should be aware of, but wouldn't necessarily be asked to do. Bladder aspiration is simply where you stick a needle with a large syringe into the bladder to aspirate urine. And this is a temporary solution just to it's kind of like a get out of jail free card if there's someone in retention and you can't catheterize them, and it's very, very painful. You can aspirate at least 500 mils from the bladder and give them a little bit of relief. Of course, it's not a temporary solution because they'll just fill up again, but it can buy you time. A catheter introducer, so that's the big metal rod you see in the bottom right. So it's exactly that. It's a metal rod that you put inside the catheter, and it just gives it a bit more firmness so that you can navigate around a big prostate, around that bend with a big prostate, and catheterize them that way. But that's a very dangerous tool in the wrong hands. Obviously, it's a big metal wire going up your urethra. A guide wire, so we have these thin guide wires which you can put in. It's especially useful if there's a stricture or a tight hole in the urethra that you can't get a normal catheter through. So the guide wire will ensure it goes the right way and you don't form any false passages. Or in patients with phimosis, so that's a tight foreskin, sometimes it's pinhole tight and shut, so you need a guide wire to navigate through and find the right lumen. A flexible cystoscopy is sometimes needed if you can't see what you're doing, or you can't see the urethra, you can't catheterize them. So you get the camera in and you can find the true lumen and use a guide wire to catheterize the bladder. And then some patients develop penoscrotal edema. So this is just like pitting edema. So especially in hospitals where they sit with the bed slightly bent so that their sacrum is the lowest point of gravity. So any edema they form will go there. So they'll get sacral edema, but it will also go to the penoscrotal area. And the edema can mean that the foreskin kind of closes shut and you can't see and they can't pee. So, but it's very simple. All you have to do is squeeze the edema out the way until their foreskin's back to vaguely what it was. And then you can pull back a little bit and see the urethral meatus and catheterize that way. So in summary, we've talked about causes of retention and we've thought of them as pump failure or outflow obstruction. You know now that there are many more indications for catheterization apart from urinary retention. There are multiple types of catheter, including single-use, two-way and three-way catheters with different sizes. And it's very, very important to understand the common complications of catheters and how to manage post-catheterization care. So thank you all for listening, and I'll hand back to Zach to see if there are any questions.
Thank you very much, Sinan. That was really useful. I hope it was as useful to me as, well, to you guys as much as it was to me. Does anyone have any questions they'd like to pop in the chat box for Sinan? Okay, so it doesn't seem like there's any questions at the moment, and that's fine. If you guys think of any other questions later on after the end of the session, feel free to just send us an email at the link just here, and we'll be happy to get back to you guys and reply promptly. Otherwise, we really appreciate your feedback. It'll help us deliver better sessions for you guys and make sure that we deliver whatever you guys want us to deliver. So feel free to use the QR code on the right to give us some feedback, and you'll get a certificate for that. And thank you again for all your attendance, and be sure to join us next time on chronic urinary retention. I'm going to pop the link for the feedback into the chat box as well for those of you who prefer to use the link. So thank you very much and have a good one. Thanks, Sinan.
Thank you.